So without further ado, I'm doing the first talk, so I think I will just crack on and get started with that a minute or two ahead of time. And the first session we have today is to look at EM research and emergency medicine research really in times of crisis, and in terms of really working out where we go for the future of this. Now, I'm going to want to share my screen, so I think that's better. Let me just share this talk with you, and I'll run through it, and we'll hopefully get some time to there we are, to discuss this and the other two talks in this session towards the end of our first session today. So we also have Ryoma from yesterday from the WHO in Japan, who will also be joining us for a discussion on his talk yesterday. So if you have any questions that you have burning from his discussion yesterday, please do let us know as well using the chat function, as Kevin has already mentioned. So I'll get started. Emergency medicine is what many of us who are on the call today know and love, and we tend to be known as the crisis specialty because of what we do. And I'm going to show you some materials, certainly from my past, that I think confirm that crisis is really our specialty, and managing the unexpected is really what we do best. And I'm going to talk a little bit about the history of research and publishing in the past when it comes to these crises, and how the current crisis of COVID-19 and its research has had a huge impact on that, and to have a think about what we need to be doing to position ourselves as a discipline and as part of a multidisciplinary approach for the future disasters and crises that we will face. So some of you will recognize this picture. This is a picture of the Kegworth disaster. This was a Boeing 737 which came down on the M1 motorway in England many years ago now, back in the late 1980s. And it landed just on the embankment of the motorway. How it missed all the cars is beyond anyone's understanding, but many people were killed in this crash, and a number of people were injured. We do actually have a very close link to this disaster in that Malcolm Underwood, Professor Malcolm Underwood, our Professor of Cardiac Surgery, was a junior doctor in Leicester Royal Infirmary at that time, and he actually attended this incident as a member of the mobile medical team and helped to get some of the injured passengers out. And he's told me many times in the past that he had to perform various amputations and things in the wreckage of this aircraft in order to extract some of the survivors. So although this is a long time ago, and although it may not seem so relevant to Hong Kong, in fact, we have a very close link with this. This is a picture of the Royal Infirmary of Edinburgh. This picture predates my time there. I was there in the mid-1990s. But this was my chief, Dr. Keith Little, and great mentor. He was a very inspiring individual. He's retired now, but he wrote his MD thesis on pre-hospital care and its effects, and really gave me a huge impetus and support to show that you could do research in this kind of environment, which is not the traditional medical environment, it has to say. And this was the first of the so-called Medic One vehicles in Edinburgh. This was an old Bedford van, and those of you who recognise the fashions of the time will realise this is back to the early 1980s. This was the van, as I called it, that I had the pleasure of serving on in the mid-1990s. This was a terrifying vehicle. When it went at more than 60 miles an hour, the gearbox started to make a terrible noise and there was a smell of smoke in the inside of the ambulance. And you never really knew if you were ever going to get back to the Royal Infirmary alive or dead, or whether indeed the van would break down somewhere in the middle, which it did not infrequently. Medic 1 went out to many crises. The late 1980s were a particularly difficult time throughout the United Kingdom, with major disasters and terrorist incidents from various sources. You'll recognise this picture. It's an iconic picture from the village of Lockerbie in southern Scotland. Lockerbie was a tiny little village in the southern part of Scotland, which became famous and infamous after a Pan Am jumbo jet got blown up in the skies above it just before Christmas in 1988 and landed all over the district, but killing many people on the ground and everyone on the aircraft. Medic 1 responded to this incident. There wasn't a lot to do in terms of the passengers on the plane, but they provided a huge amount of support and medical coverage for the people on the ground over the ensuing few days. But there were other slightly more mundane events the year after the Lockerbie disaster. This was another incident that happened in the city of Edinburgh. This was a street in Edinburgh called the Guthrie Street in a place called the Cowgate. And as you can see from the picture, the rubble here, this used to be a tenement building like the buildings behind it, until a gas pipe exploded one morning and blew up the entire tenement. And Medic 1 also responded to this incident. 2 people were killed and many more were badly injured and had to be extracted from the rubble. And remember, these are in the days before we had things like major incident medical support and other kind of formulaic methods of dealing with disasters. And we just got on with it in those days. Medic 1 has evolved enormously. My good friend and hidden in the back there, Angela Oglesby and Richard Lyon here, who now runs the Medic 1 service out of the new Royal Infirmary of Edinburgh. They moved house many years ago to a wonderful new building and facility. And this is the much more modern and very stylish, I have to say, Medic 1 vehicle now, which was funded by public money and private donations. And the great story behind this particular picture is this little guy here, who was critically injured in a car crash, and he was knocked down by a vehicle in Edinburgh when he was a bit smaller than this. And it was only through the interventions of the Medic 1 team with pre-hospital anaesthesia and the advanced life support that he survived at all. He was very critically injured. If you want more information on that, go and look at the Edinburgh Emergency Medicine website, where there's a really good video on the work of Medic 1. So how does this all tie into publishing? Well, you know, if we look at the history of disasters in the way that emergency doctors and emergency medicine as a discipline have looked at disasters, honestly, we've always seen them as a potential publication source rather than anything more than that. The next few pictures relate to a disaster that happened in the city of Glasgow, where I originally come from, back in 1982. This is not a black man, this is actually a regular Scottish guy, but he's a miner in a coal mine. And he, along with around 40 other people, were in a coal mine in a place called Cardowan, which is a few miles from the centre of Glasgow. And at that time, coal mining was still very common in Scotland as a source of fuel, just as it still is in China. And obviously we see many of this type of incident still occurring in China at the moment. And there again was an explosion with gas inside the pit, and all of these poor miners had been either burned or injured and had to be transported to hospital. It must have been a serious incident. You can see that one of the senior ambulance guys is there with the braid around his his cap. Normally these guys wouldn't have been out of their offices unless there was something major happening. And we can see the doctor in the background, complete with his pager and his white coat and his tie, how things have changed since 1982. But my very good friend and colleague, Charlie Allister, he was the senior registrar in the emergency department at Glasgow Royal Infirmary at the time. And of course, he dealt with the patients as he would, admirably, but he also saw it as a great opportunity to write a paper, because that's what you did in those days. If there was some kind of disaster or some kind of newsworthy event, you immediately wrote a paper on it and got it published. And Charlie at that time, some of you will see at the bottom of his screen, he was the senior registrar in the department, so effectively the chief resident in the department at the time. We would call him a final year trainee in Hong Kong. And it was seen as a real rite of passage that you would write up something like this, publish it in a decent journal. In those days, you could get something like this into the British Medical Journal. Now it's just a bit harder to publish in the BMJ. And that was your passport to a consultant position in those days. So how things have changed. We come a bit more to the modern era. The London bombings in 2005 led to a huge amount of proper scientific work and analyses, looking at the number of patients who came. The London bombings was a particularly a horrific event because it was in multiple different locations, 4 different locations throughout the city of London, with 775 casualties and 56 deaths. But almost all of the deaths occurred at the scenes. But this was a very good analysis that was published in the Lancet. And even more recently with the events in Paris and France, with urban terrorism taking a real forefront in the last few years. Our friends Yuri Yordanov and his colleagues and Pierre Carly from the public hospitals in Paris published their report on how they dealt with the events of November 2015. So we see traditionally, as emergency physicians, we see disasters as an opportunity to publish. And I say that only partially in jest. It really was the way things were. But the focus was traditionally always on traumatic incidents. We have only in the last few decades really seen this massive change that I referred to a few days ago in one of the talks, where emergency medicine's become more medicalized in many countries, including Hong Kong, and if anything, it's become geriatrified, particularly as our aging population has increased in Hong Kong and in other places around Asia like Taiwan and Japan, and of course into the mainland. So what about COVID-19? That's really what we're here to discuss today. We all know that COVID-19 started off as just a febrile respiratory illness, and we really didn't understand anything about it. But we all know that this comes with silent hypoxia and shortness of breath, and consolidation and respiratory failure, and all of the things that COVID continues to bring, and we're seeing in awful technicolor from India at the moment. But the emergency department remains the first port of call for sick patients. And again, we're seeing this predominantly in India at the moment. These awful pictures over the weekend of people turning up in the ED, looking for oxygen, looking for needing respiratory support, and in some cases beyond help due to a lack of preparation. And many emergency departments throughout the world were grossly underprepared for epidemic illness because, again, we think trauma is our biggest challenge, and in fact, in this day and age, it almost certainly isn't in most developed countries. This is a slide from a talk that I gave in Scotland in May 2006 when the SARS epidemic had just occurred. I was supposed to come to Hong Kong to join CUHK in 2003, but I was told not to come because SARS was in progress, and I came a few months later in early 2004. But as you will all remember, graphically, there were 1,800 nearly cases of SARS in Hong Kong and 300 deaths, including 8 healthcare workers. That statistic will tie into the next talk I'll do later this afternoon. But suffice it to say that Hong Kong's response to SARS was profound and included things like the Centre for Health Protection being established and other agencies and plans at government and HA level to try and prepare. A couple of years after that, we had visitors who came over from Addenbrooke's Hospital in Cambridge. Sue Robinson and her colleagues came over and met with Albert Litz from Princess Margaret Hospital and myself. And we had a very useful few days talking about what might be useful for preparing for a pandemic influenza outbreak. Now, why pandemic influenza? Well, that seemed to be the most likely outbreak. And in fact, this paper was published just around the time of the swine flu epidemic, so it probably was quite useful at that time. But interestingly, if we go back and look at these 10 things that are in this particular paper, what you'll find is that Hong Kong did most of them really quite well when it came to COVID-19. The UK in its initial response really didn't do very well with these 10 items that you can go and have a look at yourself. And even simple research like this, simple recommendations like this, are only as good as their implementation. But Hong Kong did well. Now, how about publications? That's really what we want to talk about now. Publications in COVID have been a real challenge, and one of the challenges in my previous role as editor of the European Journal was the hardest thing was trying to get people to actually review papers and give comments. And one of the things I wrote there was how distressing it was from an editor's perspective that often our best researchers, the ones who are good at this stuff, excuse themselves from the reviewing process because they're too busy or because they're not interested or because they have too much pressure on time. The whole point of peer review is to try and find the experts who will look and see the flaws behind the papers. But we don't get those real experts if they are busy doing the research, and that's why peer review is not infallible. But that means that new science can be put at risk. And if the reviews are not adequate or not incisive enough, then we have a problem. And that's really why we call the technique critical appraisal. It has to be critical. Otherwise, we end up with substandard information. Open access publishing has changed this because open access publishing has variable levels of peer review, some good, some not so good. But that has a profound impact on what gets published. And as I said, peer review is difficult to do in normal times, but particularly during COVID, many of our best peer reviewers are clinicians. And many of those clinicians are busy dealing with the pandemic. So their time is even more limited. But it would be fair to say there's very little evidence to support peer review, either in terms of the numbers of people involved or the type of people who are doing it. So we've got a big problem, and we have to ask the question, are the standards of peer review as high now as they may have been in the past, and especially with the pressure to turn things around quickly, given things like COVID, where we're looking for rapid responses. What has happened in the last couple of years is we've ended up with preprints, and preprints have no peer review but are publicly available. And I want to show you what happens with preprints. We end up sometimes, and this was an article in the EGM last year by Danielle Orstel, looking at the spread of fake news from politicians. And you know, I don't need to tell you who's been the most famous of those politicians using social media. And social media's impact is profound, is sometimes sensationalist, but it's often people just seeking hope because they're desperate. But it's also often wrong, and it can lead to very unintended consequences. And as the big blue bird will attest, it's often used by those in positions of power to influence in specific ways. So I looked at medRxiv this morning. medRxiv is the medical preprint server for health sciences. As of this morning at 10 o'clock, there are more than 15,000 COVID preprints. Now, these are papers that have not been peer reviewed yet. But I guarantee you that members of the media look at this every single day and look for things to put on the news. And we've seen all of these that I've listed on the screen here come and sometimes go. Dexamethasone has stayed with us as a treatment for specific sick people with COVID. Plasma, various mortality studies, ventilation rates, ECMO, remdesivir, hydroxychloroquine is the classic one, have come and often gone. And this was a paper published in The Lancet last year, which got published on May the 29th, and within a few days had been retracted because the data could not be corroborated. But what is interesting is, despite the fact it was retracted, it had already been cited 50 times. And more importantly, it had had 63,000 tweets and another 42,000 shares on social media. So this is a huge problem because it's out there, and even though it's retracted, it's still there. So you have to ask yourself as an investigator, who are you collaborating with? Have you looked at the protocols? Have you looked at the ethics? And more importantly, do you know what your collaborators are doing? You've got to have ethics approval. Even that doesn't guarantee it's going to be up to speed or up to scratch, but it's a start, and you've got to be able to see the data. But be under no illusions that pressure to publish is a very powerful driver of fraudulent research behaviour. And until we get a substitute for peer review, it's all we've got. But we should be willing to share the data at the same time as we publish the paper. So I'm nearly finished. Here's a few solutions. We need less haste, and we need more detail and transparency in methodology. We need the data to be out there and analysable. We need consequences for research fraud. People need to know that if they get caught, there will be issues, and we need to improve integrity and our use of social media. The system probably did work here, in as much as the outcry about the hydroxychloroquine paper meant that the paper was retracted within a few days, which was good. And post-publication peer review has not been traditionally used, but may have a very important role here in terms of improving transparency and reducing fraud. So finally, what is the future? Well, here we have a good example of the future in the present. This is the recovery trial, which is based from the University of Oxford. It's a big trial, which, as you can see, is 40,000 participants in nearly 200 sites. It's looking at a variety of different treatments, and it is an excellent example of where we need to go in the future. We need to think about where we stand in that agenda. I think we probably need pre-prepared protocols for different options. We need to be talking to our ethics committees, and to be fair, our ethics committees in Hong Kong have been very responsive to COVID-related applications. We need to integrate far more with our friends in the realms of infectious disease, microbiology, epidemiology, and critical care. To do all that, we need resources and staff. I think this is probably the way forward. We have adaptive trial designs now coming online. Recovery is a very good example of adaptive trial designs. And for those of you who would like more details, I'd refer you to this excellent review article in BMC Medicine from a couple of years ago. So I'm going to finish up by saying emergency medicine remains the crisis specialty. We're good at this. We do this all the time. And our research traditionally has been reactive in crises, but COVID is making us think again. We need to think about future and present approaches like adaptive trial design and the changes that that will bring. And we need a paradigm shift in where we go with this. I'm going to stop there and stop sharing, and we're going to keep all the questions to the roundtable at the end if we can. Again, I'd encourage you, if you've got questions or comments, to put your questions on the chat, and we will do our best to take those as best we can when we can. So without further ado, let me just find my timetable and things again.